So, hi, how are you? Today, I'm just starting with the first presentation of my what are the list of interventional procedures that is happening uh, in the interventional radiology department, or what are the basic interventional procedures that are going on. So, let's go to the videos. So, I divide the system into various based upon the involvement of organs like head and neck, central nervous system, respiratory system, hepatobiliary, genitourinary, gastrointestinal, reproductive system, MSK, and limbs with lymphatics and little about oncological interventions and miscellaneous. So first starting with head and neck intervention. So there are various tumors that occur in the head and neck. For example, joint nasopharyngeal angiofibroma, which occurs in young adults, which can be pre-surgical. We can have a good embolization to reduce vascularity and to have a safe surgery. And for any tumors that occurs in the tongue, in the oropharynx, nasopharynx, wherever the patient presenting with bleeding, we can have for tumor embolization. And there are other causes like carotid blowout. For example, there's a tumor or cause any radiation which causes injury to the branches of ECA or ICA. Depending upon the conditions, we can go embolize or the stent, depending upon the particular clinical conditions. So these are the oncological aspect of the head and neck. Going to the AV embolization, this AV embolization I just told because it is according to the um, face and head and neck. There are many children who present with the facial AVMs. There are many children who present with the tongue AVMs. There are like a hemangiomas. There are like a high flow AVM, A fistula, scalp AVM. This can be treated by means of staged embolization. It can be a single stage or multiple stage. A word about glomus tumor embolization, because the glomus tumor which occurs in the um, along the various aspect of the glomus body, from the medulla to the carotid body. There are various ganglions which can go to tumors, and this can be act as a pre-operative tumor embolization, or sometimes the patient who are not eligible for surgery or any they're going for radiotherapy or common knife, we can reduce the symptoms as a palliative long-term management for glomus tumor embolization. So as I told, the sclerotherapy is one of the part of an EVM embolization. So now, moving from the head, we go down. We see like a thyroid. It's a important gland. There are many interventions that are happening in the thyroid. For example, for benign thyroid tumors, we have a microwave and radiofrequency ablation for total cure for at least significant reduction of symptoms on follow-up. There are various articles that claim to reduce the vascularity by means of thyroid artery embolization. The size of the nodule can be reduced where the patients not fit for surgeries, doesn't want to have a surgery. This is also coming up for cosmetic purpose. And because since the surgery is avoided, since the tumors are benign and they can be treated and follow up, the thyroid nodule are coming up very higher level actually. Okay, and then this carotid artery angioplasty and stenting is a part of the head and neck and also CNS. So whenever there is a vessel which is the main supply to the brain, like ICA, which get narrowed, stenosed, or sometimes even there are people who do like a complete occlusion of the carotid. They will try to recanalize also. So it can be occur as an acute presenting as a stroke or chronic presenting as a multiple episode of TA and stroke. We do like a stroke thrombotomies that will show in CNS. I will tell about CNS, but here in the neck we do this angioplasty with stenting usually, and with a protection device depending upon the stent we use. And also for accidental carotid blowout syndrome is one of the conditions where there is a leak in the ECA branches, or sometimes rarely from the ICA branches also, to leading to massive hemorrhage. So in that condition, we try to embolize the ECA branches and put a stent for ICA if it have to preserve the ICA to flow to the brain, or sometimes very rarely we also do a trap, what I call a complete occlusion of the ICA when there is contralateral force very good and the patient able to tolerate the balloon occlusion procedure. And these are things that can be done in head and neck. So moving to next, the central nervous intervention is per se is an individual. It's a large spectrum of intervention. Just it's like a penumbra. Sorry, it's like a panoramic. So just few things I will tell. One is like intellectual aneurysm coiling, There can be like a simple coiling, or we can give ball nested coiling, we can have a stent tested coiling, we can have flow diverter with coiling. This aneurysm is a whole spectrum of management. So the like an AV which occur in the face, head and neck, there's an AV which also occur in the cerebral parenchyma. So this was presenting if they present with a hemorrhage, they need to they have, need to be treated compared to the outcomes of the Harvard trial. So whenever they're presenting incidentally for other purpose, the imposition is by case basis actually. So AV embolization usually done by means of liquid embolic, mostly like onyx or glue or squidge, depending upon the particular thing. With or without, like there are many techniques: pressure cooker, reverse pressure cooker, and there are various techniques that can be used in AV embolization. So CCF, cardiac cavern fistula coiling and embolization is another thing. In our country, most commonly is traumatic CCF. The patient presenting with a young male who has got a recent trauma like scooter, car injury, or something fall down. They suddenly present with the blowout of an orbit. That the whole eye will like enlarge and proptosis. So an MRI will show the cortical fistula. We can do an M coiling along with the embolization with liquid embolic agents. And there are various other carotid cavern fistula like indirect type, where there is branches between the EC and um, carotid cavernous leading to formation of fistula that can be treated by means of embolic agents or coils also depending upon the location. A dural fistula is another type of fistula where there is abnormal communication between dural arteries and veins, branches of the ECA which are communicating indirectly to the intracranial venous system, to the multiple arterial feeders. This most commonly occurs due to post-thrombotic sequelae or dehydration, something in females or some. But this is a devastating disease actually. It has a various stages and it's more the complicated. Treatment is a little difficult, but it should be a staged embolization, and the untreated urinary fistula has a very bad morbidity in the form of increased ICG, hemorrhage, loss of vision, etc. And this is very difficult to treat sometimes, but okay, but still it's possible to do fistula, mostly treated with different um, liquid embolic agents. So in patient with a chronic recurrent subacute hematoma, we didn't mention which is coming up very heavily because to reduce the arterial flow, thereby reducing the recurrent SDH. So intracranial hypertension due to venous stenosis, we can put a stent in the venous system and dilate it. So there will be no narrowing, there will be no increase in intracranial pressure, thus not causing papillary edema or vision disturbance. So venous sinus thrombosis, there are certain centers which do venous sinus thrombectomy. For example, they can put an catheter within the IJV and try to like a 40 or something like that, and try to remove the thrombosis. Also, they can go via various system also, but easy is to via the IJV and go. It's a short stick. The stroke mechanical thrombectomy is a proven method of treatment. Is a magical method where the patient for the patient is a very great benefit because it is avoiding the lifelong morbidity, and it is like a game changer, and it is the important treatment that I found in neurointervention, which is close to my heart. So then first into vein gallon malformation, especially occurs in neonates, or it is usually diagnosed like a screening obstetric ultrasound. The treatment depending upon the childhood condition, and it's a stage embolization with liquid and coils. And spinal labium, this is like a sudden disease presenting with paraplegia. When you do an MRI, we will get a AVM. So this can also be treated with liquid embolic agents, a glue on its squid, depending upon the types of the spinal labium, and it can be staged. But the prognosis wise, until it is treated completely, that is about prognosis. But this is having already, if the patient presenting with a bad, it's difficult to improve further. It's a lifelong morbidity disease. I can't. Elderly patient, comorbid condition presenting with narrowing, we can go angioplasty and stenting, dedicated stent can also happen. There are various diagnostic neurointervention like inferior sinus signing to isolate to see which side the pituitary microadenoma is there actually. So here there's many central nervous intervention that I never touched up, but this is a major thing that every bread and butter of CNS interventions going on. So moving next To respiratory system, bronchial anti-embolization, especially in case of like our countries, because still we are surviving with tuberculosis, and there are many patients presenting with chronic tuberculosis and chronic infection, chronic bronchitis. Even the bronchial anti-embolization also coming in a role in case of a large tumor presenting with bleeding. We can also have embolization. Pulmonary EVM, this is one of the rare causes which are presenting with like a cyanosis and clubbing and presenting hemoptysis sometimes early. So that case has to do with like coil or plug embolization. Bronchiality can go with particles like gel foam or PVA or even sometimes glue also. But pulmonary AVM, we cannot put a particles, it's only a metal, it's coil or plug. So tumor embolization as I told, and so AVM embolization as I told is a pulmonary AVM. There are conditions like interruptus sequestration presenting with a recurrent infection, increased vascularity. We can do on bronchial embolization to reduce vascularity. There are other things like cryoablations for lung tumors and the desmoid tumors, and that are coming up very well actually. And if you don't tell about the pleural effusion, the lung intervention, it will never end actually. So pleural effusion, there are various methods like simple putting the knee like IV vent from you to put to reduce the pleural effusion to having a permanent catheter to fix it to the chest to have a drain SNS, and also like a pleural pneumothorax. Also we can do drainage with a hemorrhage. These are the few respiratory interventions. Going to the hepatobiliary system, the liver is the mastermind of our body. So the biliary obstruction, we have to put a drain. It can be internal or external. Able to not able to maintain the drain, the stress is significant. The various conditions, you got to put a stent as a permanent. And this is what the biliary interventions. When you go into venous intervention, there's our occlusion of blood flow from the liver to the IVC. You can do your dips to divert the blood flow from the portal vein direct to the IVC, that is bypassing the liver going to the IVC. So there are various new techniques like biliary structural reconnection using like a magnetic methods, and chronic cholecystitis. Patient is not operated for surgery. We can go for GB drainage for cholecystitis. So tumor aspect of the liver, it's coming up very well because after BCLC staging, like it does include TAS, trans-arterial chemoembolization, trans-arterial radioembolization, can have drug-eluting betates. These are specific agents which are delivered more locally to the tumor, so got significant therapeutic effects. Along with the embolization, we also have an ablation. It can be radio frequency, cryo, or microwave. Usually, RFA and microwaves are used, and there also IRE, reversible electrophoresis, is also coming up. And the other thing, apart from like for portal vein hypertension, for extrahepatic curves like CARTO or PARTO, plug assisted or coil assisted or balloon assisted retrograde ablation of varices, especially for isolated gastric varices, that can be done via femoral approach or jugular approach using a coil and sclerosing agent, so that we occlude the both inflow and outflow of the varices, and so the patient doesn't have recurrent hemoptysis. Sorry, hematemesis, not hemoptysis. And for liver transplant, patient who have reduced liver volumes, we can go on portal embolization or extend the portal embolization with right and middle hepatic vein. So we try to increase the left hepatic lobe volume as soon as possible as patient gone for transplant. So in case of giant hemangiomas, usually hemangiomas are no touch lesion, don't touch until it is bleed, until has significant pain and is going in size. So that time can have embolization using like a various agents are used in hepatic hemangioma embolization that use like particles or like sclerosing agents like doxycycline, etc. Other than that, for hepatic tumors or hepatic metastasis, we have an embolization. Going to genitourinary system, there's like a the nephrostomy is bread and butter, so we have to assess the kidney above from above. The urologist is not able to assess from below. So we can put a stent from, so the urine can drainage from the kidney to the bladder by passing the ureter, and there's ureter stenosis. And in stenosis causing significant renal artery hypertension can be treated with renal artery stenting and angioplasty. Those patients who are transplanted renal artery presenting with complications like hydronephrosis or something can put a nephrostomy just for to reduce the complication. Sometimes transfusion stenosis is also common that we can do stenting and angioplasty. Renal tumor embolization, palliative and also preoperative can be done. Renal embolization can also be an incidental finding where we usually use coil or plug along with the liquid umbilical depending on the flow of AVM. There are things that I want to cover with renal, like fistula salvage, central venous angioplasty. These are things which are coming with usually with a chronic renal kidney disease patient who have created a fistula but stenosis are narrowing. That is most common in long-term fistula. So we try to put balloon and dilate it. And especially in case of long-term dialysis, the patient with central vein stenosis, we go for central vein angioplasty and stenting. And now we have like in vascular surgeon, we also can create a fistula that leads but it's more demanding and more cost. And we can put a stent, as I told. And there are a few cases like sometimes like renal vein compression. We can have Scottish nutcrackers, and we can also put a stent. The belly and causing congestion can remove the congestions also. The diagnostic aspect is antigen sampling, especially for adrenal adenomas, which is peripheral or some center. We can diagnose it from which right side or left side. We can also diagnose by means of selective adrenal sampling. Going to the gastrointestinal system, it's like we can put a stent like from esophagus to duodenum, and we can create a pathway like gastrostomy and gastrointestinal. Going to the tumors, we can embolize when they bleed. We can reduce the vascularity, but usually GA tumor embolization is very less compared to GA bleed. But GA bleed is more common, and we put a coil mostly, or sometimes rarely glue also can be used, but it's very rare actually. And whenever there is a thrombosis, we try to thrombolize and do an angioplasty for SME. When there is an SME thrombosis, we try to aspirate and put an angioplasty or put up stent. Splenic artery embolization for trauma, for hypersplenism, causing bridge abnormalities are the most common touching the splenic artery, because it is the most common organ engine apart from the hepatic artery, which is pseudoaneurysm. We're going to put a coil or glue. And for visceral artery aneurysm, which can happen in any arteries of the abdomen, like it can be like a coil or embolization depending upon the location of the aneurysm.